My name is Ajay Nooka. I'm an associate professor at the Winship Cancer Institute of Emory University. I'm the chair of the myeloma working group, as well as the medical director for the Winship Research Informatics. So understanding amyloidosis is the key for us to understand why even you need such an early diagnosis or detection, or even that high suspicion for detecting amyloidosis. So as you all understand, systemic amyloidosis is a protein misfolding disease, and the pathophysiology starts with a small clone, but can be a dangerous clone. What happens with this misfolded protein is with the addition of all the interactions with other oligomers, it can become a amyloid fibril, which is significantly tough to dissolve and can cause a lot of organ toxicity with depositions. So it is very essential for us to understand why it is so important to initially go for an early detection. I'll give you some historical data. So among the patients that are diagnosed with AL amyloidosis, on an average, the patients complained of these symptoms and had seen at least 4 physicians. Median time from the initiation of the symptoms to the original diagnosis takes close to a year. And majority of these patients have seen a hematologist as well. Now, which when you summarize, these patients had these symptoms for a while before a diagnosis is made. So early diagnosis is the key to have better outcomes, both from a hematological response perspective, as well as from an organ response perspective. So earlier treatment prevents end-stage renal disease. Early treatment prevents the cardiac toxicity that can be seen with AL amyloid. So what are the symptoms that you're all looking for? So I've focused mostly on the non-specific symptoms. This is such a rare disease affecting close to 2,500 patients in the entire United States in a year. So in all likelihood, an oncologist can practice an entire career in 30 years and fully not being able to see even a single amyloid patient is very common. So now, which brings to the point of why we should increase or heighten our awareness to start looking for these symptoms. These are always the zebras. However, you always see these in the boards only for the reason to increase the heightened awareness. So now, unexplained weight loss, severe fatigue, exertional dyspnea, these are all the most common symptoms that patients presented with. Leg swellings, including significant loss of protein in the urine, and these are all, when you're not able to point out the exact etiology, you got to think about AL amyloidosis in the background. Among all the amyloidosis put together, 2/3 of the amyloid are from the AL amyloid, which potentially can be treated by stopping the production of these amyloid fibrils, even before, so that further damage to any of these organs is prevented. Other symptoms that I always watch out for. So recently I'd seen somebody with a periorbital hematoma. My suspicion is significantly higher. Fortunately, she was seen by a primary care physician who I spoke to 3 years ago in an amyloid case. So I got a referral for periorbital hematoma now, or ecchymosis. Now we do have her being worked up for amyloid. Macroglossia, unspecified loss in the ability to speak, chewing the tongue. These are all the things that should increase the awareness or increase the suspicion for an underlying protein deposition problem. Bilateral carpal tunnel syndrome, unexplained peripheral neuropathy, autonomic neuropathy, having organomegaly in terms of splenomegaly, so hepatomegaly. All these should raise the suspicion for a underlying plasma cell dyscrasia that potentially can be treated if identified early.